to thank Jess and the team at QENDO in Canberra for the opportunity to share some of the information we have around the role of Botox in the management of myofascial pelvic pain syndrome. In other words, is there a role for Botox in managing pelvic floor overactive muscles? So that's what we're going to talk about today. To make the discussion, I'm going to first of all have a bit of a background on what pelvic floor muscles, the role they play, and how the hypertonicity occurs, and then what are the things we can do to manage it, including the use of Botox. I also touch on some of the symptoms that come on with overactive pelvic floor muscles. So, so we know that pelvic floor muscles, they provide the support for not just the lower limbs, but also the upper body as well. They sometimes they normally would elongate and contract, not as a group, but individually. And they can help with the control of bladder, bowel, and sexual function. Sometimes their performance is affected by not just the physiological stress, but also psychological stress as well. So we know that myofascial pain or overactive pelvic floor can cause chronic pain. And the pain that they cause can be continuous or it can occur as acute flares. And usually these pelvic floor muscles are characterized by being tender, tight, not just the muscles, but also the connective tissue of the pelvic floor and or the pelvic girdle. So it's also a very common condition in gynecology, in urologic, and also in colorectal pain syndromes. In fact, up to 85% of individuals that have gynae urology or colorectal pain syndromes would have overactive pelvic floor as well, and the trigger points within the muscle groups. When it comes to endometriosis, in one particular study, 96% of women with endometriosis that do not respond to conventional therapies, for example, hormonal therapy, anti-inflammatory medications, or even surgery, for example, 96% of them had overactive pelvic floor. And in endometriosis patients, like in other conditions, overactive pelvic floor can occur with painful bladder syndrome, interstitial cystitis, sometimes dysmenorrhea, vaginismus, and pain around the vulva as well. So in this study that was published about 2021, they demonstrated that women with endometriosis would often have, overactive pelvic floor and pelvic floor dysfunction, not only within the pelvic floor, but also beyond the pelvic floor as well. So areas like the lower back, the hips, the abdomen, the thighs. And in some of my patients, they discuss pain that often goes down to their ankle and their feet as well. So what is important here is that, in women who do not respond to our standard hormonal treatment for endometriosis, it's important that we know the questions to ask. Now, not just depend on repeating surgeries over and over and over again. It's important to remember, to ask the question whether we are overlooking other pain contributors that occur in endometriosis that would not respond traditionally to hormonal therapy. So that in asking those questions, we may be able to reduce the need for some of the unnecessary interventions like repeating surgeries, all over again. Because when you have overactive pelvic floor muscle, dysfunction, really, in most cases, laparoscopy will not cure you, will not improve the pain, rather it can even make the pain worse. And why I say this is because increasingly we now understand where the origins of pain in endometriosis can occur from. Not just the inflammation effect of the endometriosis lesions, but also it can come from the overactive pelvic floor as well. And indeed, psychological contributions as well. So for this presentation, our focus is obviously in the overactive pelvic floor. And it's important that we understand how it occurs. First and foremost, you could have, nerve and muscle trauma, either micro trauma or, major traumas of the pelvic floor. It can also have what they call metabolic imbalances because oftentimes in endometriosis, for example, when you have those inflammatory events occur, certain pain-producing substances are also released as well. And those pain-producing substances would then result in inflammation of the nerves that occur in the pelvis and then induce pain, from that as well. Over time, that pain, results in central sensitization of pain. So all of these features and others not listed here contribute to the formation of this overactive pelvic floor and the formation of what we call trigger points. And ultimately, because of the way the pelvic floor is organized, it would then result in some of the dysfunctions that some of our patients, experience. So what are these symptoms, by the way? Patients will talk about pain in the pelvis, not just in the vagina and the vulva, but also around the rectum and the bladder. There are some patients talk about pain that go to other parts of the body, like the thighs, the buttocks, the hips, the lower back, the lower abdomen. In fact, in endometriosis pain, any pain from the belly button down to the knees, can be endometriosis. And sometimes these symptoms are aggravated by specific, positions and activities. And indeed, it can be triggered by stress. But what about the quality of the pain that we have with overactive pelvic floor? It's important that we realize, pain like throbbing pain that is constant, shooting, stabbing, burning pain, cramping pain, all of these types of pain are often associated with myofascial pelvic pain syndrome. And indeed, in some of our patients, they describe sensations of UTI symptoms when the pains flare up, even though there is no proven UTI on tests. Sometimes also wearing tight clothes can also result in discomfort of the pelvis. All of this is a function of the overactive pelvic floor. I've also mentioned the issues around psychological stress and trauma being a trigger for flare-ups of overactive pelvic floor. So how do we treat these symptoms? The goal of treatment really is to have less intense flares of pain and also to have fewer acute flares of pain. And there are a number of factors that we have available to help us address this. Indeed, the central feature here is pelvic floor physiotherapy. So it's important that women who identify to have this commence pelvic floor physiotherapy because early recognition and then intervention with physiotherapy can oftentimes prevent the progression to chronicity and then making it more difficult to manage in that sort of scenario. So there are a number of different options there. You can have physical therapy, which I referred to, which is the central feature in overactive pelvic floor. You could have drug therapies. You can have counseling, for example, CBT counseling, processes or therapies. Then you can have surgical therapies as well. Surgical therapies would include things like what are called trigger point injections. They could include pelvic floor Botox, and sometimes also the insertion of neuromodulator, devices in the lower back to help stimulate or change the stimulation of the nerves supplying the pelvic floor muscles. But today, our role really is to talk about Botox, as an option for us. Now, a number of studies, which I'm going to go through some of them, have shown that with Botox, it reduces the muscle spasms and self-reported pain in a number of patients. It also reduces the use of other pain medications as well. And indeed, even in our own experience here at Junic, the effect of Botox can last, up to 6 months or more. It's important to realize that, to note that, Botox can be repeated because, in order to sustain the response, you may have to have repeat injections of it. But what is critical, though, is that for women who find it difficult for some of those internal maneuvers around pelvic floor physiotherapy, use of Botox improves their responsiveness to those internal maneuvers in physiotherapy. The other thing that's important here is that the Botox for the pelvic floor is not FDA indicated or approved, So when we use it, for pelvic floor, we use it off-label. So it's important that everyone knows that. And when you have the Botox, it's important that you also wait up to 3 months before trying to get pregnant. There have been reports of people who use Botox and they gotten pregnant having congenital abnormalities, following that. So it's critical that women who have Botox remember to have additional contraception in the 3 months following the Botox injections. So this is one of the big studies that we know, that reflect the role of Botox among those women with endometriosis that are not responding to conventional therapy. Remember, we talked about conventional therapy as including the use of hormonal therapies, for example, like the pills, the use of anti-inflammatory medications. In fact, even surgery is considered a conventional therapy for endometriosis. But for those who do not respond after all of those different options, it's important to realize that Botox is an option for them. And in this study, there was an 83% response to Botox among those who had symptoms persisting after conventional therapy. And those 83% that reported, responded to Botox, they reported up to 40% improvement in their pain that lasted up to four months in this study. So across the world, in the last 2 or 3, the last 1 or 2 decades, we have had, lots of papers and research coming out showing that Botox, improves quality of life, dyspareunia, dyschezia. It also improves patient-reported pain scores, usually noted at about 6 to 12 weeks. There is also evidence that Botox can improve the pelvic floor resting pressure and thereby reduce that sort of constant ache and cramps that occur when you have a high pelvic floor resting tone. And in all of this, we understand that pelvic pain or pelvic floor dysfunction can adversely affect quality of life. And there's evidence that Botox is promising in the use of, in the management of this, debilitating condition, particularly those who have refractory pelvic floor muscle dysfunction. In this case, patients who have pelvic floor dysfunction that go to physio, and despite their physio sessions and doing all the things that are recommended for them, they still find it difficult, the symptoms still persist. In those sort of women, again, Botox has got a role. However, it is important to realize that all of these studies being, published and reported on, none of them is at yet a randomized controlled trial that is double-blinded as well. So we're very happy to announce that as we speak, there's a study going on in the Netherlands, in Europe, which is a multi-center study, is double-blinded study, and a randomized controlled trial. And this should help us answer some of the, questions around the role of Botox and confirm that for us in detail. Finally, so that we can begin to get access, to perhaps government-funded opportunities for managing pelvic floor hypertonicity with Botox. So at Junic, we've offered nearly 100 patients in and around Canberra Botox. We do our procedures under general anesthesia as a day procedure. In some cases, we do it in combination with other surgeries that we offer. We've noted that over the last 5 to 10 years of use of Botox at Junic, it's a safe procedure. We've not had any incontinence of urine or some of those common side effects that are often people are concerned about. We, however, have a selection criteria for use of Botox. It's not everyone that comes through our door that we find suitable for Botox, and we always discuss that in details with some of those patients. When we do use Botox, there are specific muscle groups that we are targeting when we use it. But more importantly, before and after use of Botox, we tend to encourage patients to continue their pelvic floor physiotherapy. Indeed, we recommend that within 2 weeks of the Botox injections, patients should try and return to pelvic floor physiotherapy. And we have noted significant improvements, in vaginismus and in re-engagement with pelvic floor physiotherapy. in the intensity of the flare-ups that occur in return to exercise. In fact, one of our patients that we had the Botox on eventually ran a marathon, not too long ago, and also reduces the need for strong analgesia. And then in some of our patients who have had, chronic pain, return to emergency all the time after Botox, they have actually wanted to get back to work as well. So these are some of the experiences that we have. And I think that as time goes on, it is unfortunate what has happened in Canberra, where the use of Botox in the public system has been restricted, even though people that led that restriction are no longer working in Canberra now. However, it's still available in Canberra through the private systems. And for anyone who is interested in getting more information, we're more than happy to review our clinic and then discuss that in detail with you. So that's, in a nutshell, what is happening in the Botox world around overactive pelvic floor. As we continue to understand, some of those different contributors to pelvic pain in women with endometriosis, some of these treatment options will continue to emerge. So I'd like to thank you all very much for the opportunity to share this information with all of you. And I look forward to getting lots and lots of questions from you, either through just electronically, even through phone calls to clinic. Thank you for your time.
Thank you so much for that. I had a question. The study in the Netherlands, when does that look likely to, like the results to be released? Any idea?
Look, at the moment they are recruiting right now. So as their recruiting is going on, I think maybe another year or 18 months, we can start getting preliminary results now.
Okay, all right. That's good to know. I did have another question. A member wanted me to ask, what is the average relief, like months, that most people get from these injections?
Look, I think 6 months is recorded in literature. Most of the literature is 6 months. And I think that we can stretch in some of my experience with my patient, we can stretch it up to 12 months with ongoing physio.
Mm-hmm.
So that's why it's critical that patients that have the Botox, will continue physiotherapy as well. Because the idea with that is to train the muscles again. That's the idea behind that. So that they get they get more elongated, they don't get shortened as they were, prior to the Botox. So the Botox gives you the opportunity to use it. In addition to physiotherapy also, there are other things that we have available as well, like, PV, diazepam, inserts, and other types of inserts that we often use as well. So all of those different contributors can delay the repeat, if you like, of the Botox injections. But I think on the average, Botox alone, about 6 months.
All right, that's pretty good actually. The only other question I have is about the spinal cord stimulator. Does that sort of help prolong the effects of Botox, do you think? If someone has that?
The spinal cord stimulator is a different sort of, setup altogether, right? I think that's the, if you like, the final bus stop in managing people with overactive pelvic floor. I think that if you have, Botox and it's repeatedly failed, that is just the final stop for you there, because the idea behind that is to stimulate the muscles differently, so they can get more relaxed as much as possible. But as you know, it is an invasive procedure, and it has its own, side effect profile. I don't do it myself, but I'm happy to, share information with people around those that do it in Canberra. About
Yeah.
one or two people I know do it in Canberra.